Good evening, everyone, and welcome to the Brian Crombie Radio Hour. I've got Dr. Eileen de Villa with us tonight, and she served as Toronto's Medical Officer of Health from 2017 to 2024. And in this role, she led Toronto Public Health, the largest local public health agency in Canada, serving the city's over 3 million residents. What a job that must have been. My gosh. How did you deal with everything that we've gone through in the last couple of years? Tell me about that experience, if you could.
Yeah, no question. It was both an interesting, challenging, and exhilarating time all wrapped up into one. And how does one get through that? As you do with any major endeavor, with a team of fantastic people around you who are committed to actually delivering on the objectives.
How did you first get into public health? Tell us, if you could, a little bit about your background and how you got to become Toronto's leader of public health.
Yeah, of course. Well, I come from a medical family. My parents are physicians. My grandfather was a physician. I have aunts and uncles and cousins who are physicians. So one might say that medicine is kind of in the blood. That being said, I didn't take it for granted that I would just become a physician. I explored a lot of different things. And I think at the end of the day, what really turned me on to the notion of medicine and public health in particular were internships that I was able to do in the United Nations system. There you could really see, how medical advances in technology could make a difference, but do so at a population level. And it's not always about medical advances in technology. It's often about the conditions within which people live. And if you can actually make a difference in those, you can really actually give people the opportunity to reach their full potential.
That's interesting. What did you do in the
Yeah.
United Nations system?
Well, I did a couple of internships. I was fortunate to be able to work in Vienna, Austria, where I worked with the United Nations Industrial Development Organization. Fantastic little organization that actually helps countries who are, without really great relationships with other partners to develop their own pharmaceutical industries for basic drugs, things like Tylenol and aspirin and antibiotics. Every country needs those. And if you're constantly having to purchase them from other countries, it's often more expensive for a government to provide those necessary medications. So this little branch of the UN actually helps organizations develop different industries, and I worked in the pharmaceutical industries branch there. I also had the opportunity to work in New York at the United Nations Population Fund, and as well in the Philippines in the same organization. So lots of really interesting opportunities in maternal and child health, and as I said, back in Vienna in pharmaceutical industries.
So, obviously not the United Nations, but US aid has come into the news quite a lot lately. Do we have a role to play in public health elsewhere in the world other than our own country?
Well, there's no question that the health conditions that exist in other countries have impact on us, especially when we talk about a nation like Canada. We are a nation comprised of those who have immigrated from other countries, and we have lots of back and forth travel, appropriately so, between many different nations of the world. So, any disease, any issue is just a short plane ride away from us. So the more the conditions are better in other countries, the healthier we are going to be here in Canada or anywhere else in the world. So I think we do have a role to play, and it's now up to our government officials, particularly at the federal level, to really think through what does that look like and how do we best contribute? Where are our skills and how best can we make others healthier so that we here in Canada can actually enjoy better health? And we've seen that.
I don't want to ask you a political question. I just want to ask you a sort of a conceptual principle question. But as we see, the cuts in the United States to U.S. aid externally, internationally for public health and things like that, and one of the political parties in Canada similarly talking about cutting down foreign aid. Is that a positive or a negative? Do you think?
Brian, I don't think that's a political question. I think that's a question of fact. And there are scientists in the United States in particular that have worked on this question, and they are actually making estimates in respect of what kind of impact might we anticipate. And again, the stats are for the United States, but we have no reason to believe that similar things won't happen here. So what they've modeled out, looking at what USAID has done and what it has been able to prevent, in the absence of those services, they're anticipating a significant increase in the United States and throughout the world of HIV, things like tuberculosis, things like paralytic polio, diseases that are actually preventable. We have the technology to prevent these diseases. The question is whether we globally have the will to use the available technologies to stop this. Not only are we talking about saving lives and making people healthier, but at the end of the day, when we're able to stop preventable diseases, we actually make for better economics and better productivity as a society, which I think we can all agree is a good thing, regardless of your political stripe.
No question. So, you said you grew up as a part of a medical family. You probably could have become a blah, blah, blah doctor or surgeon and made a lot of money. Why would you choose public health? And the way you're talking about it, it's not just public health, it's really preventative medicine rather than doing Botox for people.
Well, medicine by and large is around treating people who are sick. And that's a noble thing and it's an important thing because as humans, we will all encounter illness at some point in our lives. I think that's an inevitable. But for me, my mission was always about health. And as a result, my thoughts were, and the science shows, that what actually gives rise to health and helps us as individuals and as a community to maintain health are actually things way outside the scope of healthcare. So as important as healthcare is, when people have heart attacks, when they break a bone, we need to have acute care. We need to have medicine to help them recover, to treat and recover. But if you're looking at what really is at the root of health per se, right? What makes us physically, mentally, socially able to enjoy good well-being, it's actually about conditions that are outside of healthcare. It's income, it's education, it's housing, it's social connectedness. And the better thing to do is to start life off healthy and stay that way for as long as possible. And that's fundamentally what public health and preventive medicine about. And for me, that was a really exciting area to pursue. As great as surgery and all those other things are, for me, it was about how do we start life healthy and stay that way for as long as possible.
Sorry, did you say housing, income,
Yes.
and
Yes.
social interaction?
Those are just three. I can keep going down the list. At the end of the day, what gives rise to health, what allows us to start life healthy and stay that way for as long as possible, are the conditions within which we live every single day. Right? I don't think that's a big stretch. And I'm sure many people will appreciate that that's really what is at the core of good health. Right? The better your housing, the more secure your housing, the more you have access to the kinds of supports you need to maintain that housing, the healthier you're going to be.
So are you making a simplistic argument that if we spent a little bit more money on better housing and income supports and encourage people to get some social interaction and maybe some diet and exercise and sleep and stuff like that, we could actually solve some of our healthcare crisis and not have to spend so much time and so much money on actual sick care?
Yeah, and Brian, that's not just an argument I'm making based on opinion. In fact, it's been borne out in many studies. Whether the studies are here in Canada, in the US, countries around the world, this has been shown time and time again to make a significant difference in the health status of a given population. So yes, at the individual level, and yes, at the community level.
Well, this is going to be an interesting conversation today with Dr. Eileen de Villa, the former head of public health at the City of Toronto. We're going to take a break for some messages and be back in just 2 minutes. I'm going to ask the doctor, obviously, about vaccine hesitancy, about measles, about the COVID-19 response, about are we ready for the next pandemic, etc. Stay with us, everyone. Back in just 2 minutes. Welcome back, everyone, to the Brian Crombie Radio Hour. We're chatting tonight with Dr. Eileen Davila. She served as Toronto's Medical Officer of Health from 2017 to 2024. My gosh, that would have been through probably the busiest time a public health official would ever have to serve during, obviously, COVID-19. It's the largest. Toronto's public health is the largest public health agency in Canada, serving over 3 million residents. Dr. Davila earned a bachelor's degree from McGill University, her Doctor of Medicine and Master of Health and Health Promotion from the University of Toronto, and a Master of Business, an MBA from the Schulich School of Business. Interesting that you've got a Master's in Health and a Master's in Business. She's a public health physician, author, professor, and public health figure. She's at the forefront of public health efforts and interventions in Toronto for the last 8 years, includes guiding the city's COVID-19 pandemic response, largest vaccination campaign in Toronto's history, the response to the ongoing drug toxicity crisis, and public health policy considerations for city planning, emergency preparedness, and disease prevention and control. Dr. Eileen, it's a pleasure to have you here today. Let me ask you a couple of questions and go through some of those issues that I'm sure are on lots of people's mind. Almost every day we get updates on measles in Ontario, and we had bunch of negative comments about how high the measles outbreak was in Texas. We're actually beating Texas and having more measles. What's going on?
Well, unfortunately, what we're seeing is the result of under-vaccination. And there are several reasons that may be underpinning that. But we know that we have a situation here in Ontario, largely concentrated in the southwestern portion of the province, where we are seeing some measles transmission. And again, what we have is under-vaccination of a population. At the end of the day, measles is an infectious disease that used to take away the lives and wreak havoc amongst our population. One only has to go down to an old cemetery anywhere in this province. Look for, the headstones from the early 1900s, and you'll see many, unfortunately, that are of young children, headstones in our cemeteries, a few months of age, a few years of age. And certainly one of the causes for death at that time would have been measles. We now have an effective vaccine that actually is excellent at preventing measles. And we have been using it to great effect. There have always been some populations in our province that have expressed a little more hesitancy with respect to taking up vaccine. And of course, during COVID, vaccination and immunization schedules were disrupted, and some misinformation and disinformation has unfortunately led some people in our communities to question vaccine. I would encourage people to make sure that their vaccination records are up to date, that their children's vaccination records are up to date. And if you have questions around this very safe and very effective vaccine, speak to your healthcare provider, speak to somebody you trust who knows your family and understands your circumstances. This is a situation that can be brought under control because we do have an effective vaccine, a technology that actually works, but it has to be used.
So tell me what happens in a community. I've heard stories of people that have got the vaccine, but still contract measles because it's so prevalent in the community. Is that actually possible?
So again, there is no perfect with a vaccine. It is not 100% solution. There is no technology. There is no medicine that is 100% perfect. I think that applies not only to medicine. I think in life, there's no 100% guarantee on anything. What we can say is that the science shows that it significantly reduces your risk of contracting measles, especially if the area around, the people around you are well vaccinated, because there will always be some people who cannot get vaccinated for medical reasons, all the more reason to make sure that we are as vaccinated as possible. But yes, there's always a small chance. Part of it depends on when you got the vaccine, if there was enough time to develop immunity between getting the vaccine and getting exposed to the disease. And of course, we know that ideally you get good protection with 2 doses of measles vaccine given at an appropriate schedule. So is it a perfect vaccine? No, but it is excellent and it is safe. The interesting thing is that in an unvaccinated population, and we know this from our previous history before there was a measles vaccine, for every 1 case of measles, it would then give rise to up to another 20 cases of measles. This is a very infectious disease. It transmits easily, and it often transmits before people even realize that they've got measles. Hence, vaccination.
We heard all these stories about vaccine hesitancy in the United States and particularly in the southern United States. And yet we're worse in the statistics in Ontario. What happened in Ontario such that we've got this huge outbreak of measles right now? Is it just people concerned about vaccinations?
Well, I think you need to look at the timing of the different outbreaks. Again, ours started a little bit earlier. The current outbreak in the southern United States started a little bit later than the current one here in Ontario did, as I understand it. So we may just be seeing a reflection of time, right? We just need to see how these outbreak progresses, these 2 outbreaks progress, and you can compare, right? You'll have to actually compare, but they're not done yet. So understanding the circumstances, again, this is what the science is about. Let's not premise our arguments on conjecture. Let's actually look at the facts and understand what happened, when we have the opportunity to look at the data, and then make good plans, right? That's good practice, good professional practice. What worked, understanding what didn't, and then fixing it so we do better the next time.
I've heard reports that people thought polio was gone and that it might actually be coming back because of vaccine hesitancy. Is that true?
So there are certainly challenges, yes. And all of these infectious diseases that we have conquered or at least tamed thanks to the vaccine advances that science has brought us. When rates drop, when vaccination coverage drops, inevitably those infectious diseases will come back. That's why it's really important to have those conversations. And again, to my mind, the science also shows that the best way to actually talk about vaccine is with a trusted professional, right? Get informed. And unfortunately, as much as many of us rely on the internet for our information, there is so much misinformation and disinformation on online platforms that it's actually very, very difficult to discern what's true, what is based on good science, and what is actually just misinformation or worse, disinformation. Hence, I think it's best to speak to people that you trust, healthcare providers that actually know you, know your family, understand your circumstances, and importantly, understand the science as well.
You've undoubtedly read the reports of this individual that I think was pretty senior at the NIH in the United States that resigned or was fired, I'm not sure which, because of deep opposition to the new Secretary of Health, Robert F. Kennedy Jr., who, and I guess the simplistic answer is that he was asking them to come up with studies that proved his belief rather than them being able to publish the studies that they thought were right. What's your assessment of what's going on with this resignation of this senior person at the NIH?
Well, without knowing the details of those circumstances, very difficult for me to comment. I've learned over the years that, there's what you read in the news and then there's what really happened. But what I can tell you is this, right? The process of science should never be, true science is never about, let me confirm or let me find a way to confirm my pre-existing belief, right? When we look at science and the scientific process, it should be the constant study of the question from different points of view, but with an honest and objective look at what are the facts. And science is not, it's not definitive. It is a process. Our knowledge is something that is constantly evolving. If there's something that I hope we learned from the COVID-19 experience, it's that when you're dealing with new issues and dealing with emerging infectious diseases or anything that's a novel issue, one has to keep studying and looking at it objectively and then adjusting the course of action premised on what you understand, on the new and evolving understanding. Nothing is static. We're constantly learning, but it should not be done in a way that we assume that we understand what's happening. And now I'm going to look for facts that confirm my pre-existing belief. That's not science. And that's not how we deliver best for our community, whether it has to do with health, whether it has to do with economics, or in any realm of human activity.
About 5 years and 2 months ago, I was traveling in Boston at a conference, and someone came down with COVID-19, and we were all told to stay at home. And this was about 3 weeks before the world heard about COVID-19, and so we were some of the first people that were told to stay at home. What was it like? For us, it was shocking. We didn't even know about it. It hadn't hit the news yet at the time, and this was February of 2020. You were at the epicenter. What was it like in your job as you heard the first reports of COVID-19 and of people being sequestered before the rest of us, mid-March of 2020 actually ended up hearing about it? Tell me about your life then.
Well, it was all COVID all the time. It was very all-consuming, as you can well imagine. Actually, by February of 2020, we had already had our first case of COVID-19 here in Toronto. And in fact, if you look back at the public record, for us at Toronto Public Health, we put out our first press release at the end of the first week of January. We were hearing about what was called then a pneumonia of unknown origin in and around the area of Wuhan, China. This may sound familiar to you and to some of your audience. So we put out a press release about this issue. And just a few weeks later, on the 25th of January, we informed the public, along with the provincial officials, of our first case here in Toronto and in the province, of course. So by February, we were already deep into COVID response, although at a much lower level than it eventually became. So it was day and night, and our teams were working really at all hours of the day. When people ask me, especially in the early days, what did the days look like? It was constantly receiving information from all over the place and trying to make sure, what's good information, what's not as good information, how do we make sense of this so that we can communicate well with the public and advise around how best to manage things. Of course, it's not just communicating with the public. In the realm of public health, we're working with local politicians, the Board of Health, the mayor, to make sure that they understand what's happening and can provide leadership at the city level, to say nothing of the province as well. So it was an all-consuming endeavor. And I tell people, the short days at that time were the 12 to 16 hour days. The long days were the 18 to 20 plus hour days. And it was challenging, but I know that we were doing everything we could to make sure we were providing good advice and good information.
How do you think we did? What's your assessment of how Toronto, how Ontario, how Canada did in dealing with COVID-19?
Well, I think in the grand scheme of things, when you look at, deaths, given that was, reducing the number of deaths and the impact to health of COVID-19 was one of our key objectives. Relative to most other countries, we did pretty well on that objective. We also had in mind that we were trying to protect the healthcare system as best as possible so that it would be available to treat people with COVID and, of course, to treat people with the other inevitable illnesses, especially the acute ones that come up. I think we did reasonably well, but of course, the healthcare system continues to try to catch up with some of the backlog. It was a very challenging time for them.
Former
And
President Obama at the Democratic convention said from the stage that Canada had 1/5 the mortality on a per capita basis of the United States. That's not really a statistic that people have focused on. And you know, in the United States, they certainly haven't focused on it. They don't realize the difference in mortality. Do you think that is important and that should be sort of more publicized and people should be made more aware of that? That, you know,
yeah,
four
absolutely.
fifths less people passed away that
That's
would
right.
have.
That's right. But that's a testament to what we did together as a community, right? And I can tell you that Toronto was an exemplar of this. We had amongst the highest, like a diverse city like Toronto, as big as we are. We were at the top of the list when it came to major cities and our vaccination rate. We did extremely well, if we can use those terms, in terms of mortality rate. But that's not to take away from the fact that we lost thousands of people in our community. And I think that's a really important thing for us to reflect on. As well as we did, we still lost thousands of people. Thousands of lives were lost, to say nothing of the people who continue to have long COVID symptoms and they're suffering. So, you know, I think we should be proud, if you will, of the successes we had. But I think we also, if we're going to be good professionals and real community members, like true citizens, will think about the lives we lost, the people who continue to suffer, and figure out how do we, how do we honor those lives lost? How do we work to make the lives of those who continue to suffer with long COVID better? And I think that's our challenge in front of us, even as we recognize and appreciate where we did well and how we did relative to others.
I keep hearing about people getting COVID. Is COVID still here? Is it gone? Should we still be getting boosters, vaccines? Tell us the current status.
So COVID will be with us for the long haul. I think we should anticipate that, like other coronavirus that have emerged, they will, this disease, this virus will be with us for the long haul. With respect to vaccination and advice, I would suggest to people that, again, you always have to look at the individual circumstances. It's difficult to give general advice other than to say, look, those who are at higher risk, the last piece of advice from our National Advisory Committee on Immunization was those who are at higher risk, who are older in age and have pre-existing medical conditions, should consider COVID-19 vaccination as a method to protect them. We know that COVID-19 illness is more severe and more likely to lead to hospitalization and even death for those who are older and who have pre-existing medical conditions that make their immune systems a little bit weaker. Those are people who should absolutely consider vaccination. For everybody else, it's less strong a recommendation, but certainly worthy of consideration depending on what you do. What are your circumstances? Do you work with people? Are you likely to be exposed to COVID? You know, again, there's each individual has to really think about their circumstances and have conversations with trusted healthcare providers to understand what makes the best sense for them.
So like the flu shot, something we should be getting on an annual basis or more often?
Well, thus far, the advice has been, to get regular COVID-19 shots, especially for those who are at higher risk. And, again, as the science evolves and as our understanding evolves, we'll continue to see, does that advice change? This is still a relatively new disease for us, right? Only 5 years that it's been around in our environment. And so we're still studying. So I would encourage people to keep informed through official sources like the National Advisory Committee on Immunization, like their local public health units, and like their own individual healthcare providers to understand what makes the best sense for them.
We're chatting tonight with Dr. Eileen Davila, the former head of public health in the city of Toronto, about her experience, about her background, about vaccines, about diseases, about international health, and about COVID-19. You know, after SARS, we had a judicial inquiry into our response to SARS. I want to ask our guest after our break, should we be doing the same thing on COVID? Have we learned? Are we ready for the next pandemic? Stay with us, everyone. Back in 2 minutes. Welcome back, everyone, to the Brian Crombie Radio Hour. We're chatting tonight with Dr. Eileen Davila. She was, for most of the last 8 years, head of public health in the city of Toronto and responsible for, obviously, our city's response to the COVID-19 pandemic. Doctor, I want to ask you, I've interviewed a couple of different people about SARS. SARS, I think, was 2003 or something like that.
That's right.
And after SARS, we actually had a judicial inquiry in the province of Ontario as to how our response was. And the people that I interviewed said that, almost none of the recommendations of SARS were actually implemented. And they said that we needed to have PPE, we needed to have respirators, we needed to have ventilators, we needed to make sure that people that were working in seniors' homes didn't go on contract positions from one seniors' home to another seniors' home. That they said that a lot of the things that went wrong with SARS we understood and had analyses of in this judicial inquiry, but we didn't actually implement it. Actually, they said that we had a bunch of ventilators, but we didn't turn the inventory, and so we let them, become defunct and unworking. And so I guess my question is multifold. Number one, should we be doing a similar analysis of our response to COVID-19, whether it's a judicial inquiry or a royal commission, or just having smart people like you take a look at it? And more importantly, whether it's that inquiry like that or not, have we learned our our lessons, and are we ready for another pandemic? Or no, another pandemic won't come, so we don't have to worry about it.
So on the last question, another pandemic will come, period. I don't think there's any question in the science around this. We have had pandemics throughout history. They will continue, right? This is, for as long as there are people and for as long as there is, humanity on this planet, we will have pandemics. So that's a non-issue whatsoever. And I think that when one looks at what is good professional scientific practice, understanding what happened in any given situation, yes, including pandemics, studying what happened, gleaning lessons learned, understanding what went well, and where there are areas for improvement is a fundamental component of good professional practice. I think it's a fundamental component of good public service. And I think it's a fundamental component of, a good society to do those kinds of studies and to really appreciate and understand what has happened in the past and how we do better for subsequent situations. So I do think that there is something very important there. I can tell you that at the local level, within organizations, we are constantly studying our actions and understanding with each response what worked well, what could have gone better, and how do we then implement opportunities to improve. I think that if we're to be good public service or good public servants, and to ensure that our public, the public that we serve, has faith and confidence in that which we do, we have to constantly demonstrate that we are setting objectives, delivering on those objectives, and improving in those areas where we're not delivering as well as we could be.
With the election in the United States and Robert F. Kennedy Jr. becoming Secretary of Health, with some of the publication and publicity around the trucker convoy in Canada, with general sort of comments in the public sphere about vaccine passports and opposition to some of the lockdowns, et cetera. It's almost as if the anti-vaccine forces have had more publicity than the pro-vaccine. There were a lot of people. There were 15, according to polls, there were 15% of the Canadian population that were supportive of the trucker convoy and of sort of an anti-lockdown attitude. I worry that sort of the majority haven't been vocal and haven't been publicized, and so therefore this vaccine hesitancy has grown, and we're more at risk today. And I think about during COVID-19, supply chain issues became a big factor. And the then president, it's shocking to remember, but the then president, Donald Trump, stopped the export of personal protective equipment from the United States to Canada, and said that vaccines that were produced in the United States had to be used in the United States first before they would be allowed to be used in Canada. And so therefore, ensuring that we had local manufacturing for PPE and vaccines were big issues. But we've sort of forgotten about that. And so, again, I ask you, have we learned our lessons, and are we doing the right things? And maybe one of the things is to remind people how critically important vaccination and having a local domestic supply of PPE, ventilators, vaccines, et cetera, is. Are we doing that right thing, or are you worried?
Yeah, so I would agree with you that we do need to communicate those messages, that these are the things that are being done. This is why vaccine is so important. But I think one of the components here, Brian, is the fact that fear is much easier to sow in people's minds than is getting accurate, correct information in respect of this is what the vaccine does and this is how it works. It's a heck of a lot easier, actually, to create or instill fear or to spread misinformation, and in some cases, outright disinformation. That doesn't mean we shouldn't continue to press on delivering good science and good evidence and good information to the public. It just means that it is much slower and it is much harder to do. I think there is much that's happening. Could more happen? Yes, I think so. And we are seeing people trying to use different channels, more healthcare providers, public sector workers, public health folks, using different channels in order to reach people in a way that they're likely to be reached, and in a way in which they can hear the message. And, at the end of the day, the only way we're going to be able to tell if we've learned our lessons is as we, respond to each new situation, whether it's of an infectious disease nature or not. Are we actually demonstrating improvements and changes that have come as a result of our experiences? I think the other interesting thing, of course, is that in this time, as we talk about tariffs, which seem like they have nothing to do with health, but you've just spoken, right, yourself around having supplies, having our own industries, whether it's for manufacture of vaccines or manufacture of personal protective equipment. This is very much germane to the conversation of tariffs. And as you can see, directly ties in to our ability to be resilient in the face of emerging infectious diseases.
Correct me if I'm wrong, but I think the statistics were that the area of the greatest mortality was seniors' homes.
Yes.
And after SARS, it was similarly the same situation, regrettably. And some of the suggestions that were made were, maybe simplistic, but that contract part-time workers that would go from one seniors home to another seniors home needed to end, and they recommended full-time people. So there wasn't as much movement between seniors homes, because that was one of the reasons why SARS spread. Nothing changed there, and so COVID-19 spread the same way. So I got to ask you, what went wrong with seniors' homes, and should we be doing something different today?
Well, first and foremost, we know that COVID-19 had more serious impact on older individuals. No question, right? We have recommendations for vaccine for those who are of older age and those with chronic medical conditions. These are exactly the people that you see within the context of senior homes. Now, I'm not in the business of long-term care, so I am perhaps less able to speak to the specifics of that which happened within long-term care. However, what we can say is that clearly there are opportunities to improve. You're right. whether it has to do with how workers are employed within the context of long-term care homes, there are changes that can be made. And those now rest with the leaders within those sectors and our elected officials to determine how best would they like to put the resources, where can they make the greatest difference, what other changes can happen within the context of long-term care so as to reduce the risk for people within long-term care. So, for example, the kinds of things that were done during the COVID-19 pandemic were that long-term care residents and the workers there were amongst the first to get vaccinated. That's an example of using the science and using our, the tools that are available to us to best protect those who need it first, who need it most, I should say, first. Those are the kinds of things that I think we can do with knowledge and, again, with open discussions with leaders in long-term care and with our elected officials.
Some of the criticism of our response to COVID-19 was that information changed. You're supposed to wear a mask. You're not supposed to wear a mask. You're supposed to wear a mask. That vaccines, you won't get sick, or no, the vaccine helps, but you still could get sick. It's just you're going to get better quicker. You should lock down everyone. No, you should just lock down older people. That we, close parks, and no, we need to open parks and get people to exercise. So tell me about, what it was like during those first couple of months and the changing information. Is that fair, that criticism of the changing information?
So I will say it is fair to say that the advice changed over the course of the pandemic. Whether you can call that fair criticism, I would take some argument with, because in fact, what we were watching was the evolution of science, right? As knowledge was coming in, remember, this was a brand new virus, never seen before, first identified and actually sequenced in January of 2020. Actually understanding how it transmitted and what kind of impact it had on individuals was something we were learning in real time. So personally, as I was trying to sort through with my team the information that was coming in, there was always the challenge of trying to understand what was good information and what was, less reliable information, and how do we communicate that to our public. So if you look back at the communications that we did at the time, I hope you'll see that we were constantly trying to say, what we're advising you now is a certain course of action based on the knowledge as we know it today. And that as things change, we will keep you informed. The same thing with the kind of communication that we provided to our elected officials. These are the facts as we know them, but it's constantly changing. We're dealing with a brand new virus. It is the first time the world has ever seen this. So by definition, we don't know everything. And as we learn more, we're going to inform you of what we've learned. And yes, the advice may change as we learn more. I think that's what you expect out of a learning system or a learning organization. If I can use that language, that's something that I think people within the realm of business understand, that when you're dealing with new circumstances, there will always be a certain amount of uncertainty, and that you need to adjust as new information comes in and as your understanding of the circumstances deepens and grows.
Some of the anti-vax people or vaccine hesitancy is caused because there's a belief in some people that vaccines cause autism or other autoimmune diseases. What's your sense of that? What's the science say?
So the science the talk out there was a paper published, more than 20 years ago. I believe it was about 25 years ago now, that falsely linked mumps, measles, and rubella vaccine with autism. That study has since been discredited. The author of that study was shown to be in a significant conflict and was actually stripped of their medical license. So there is no truth to that whatsoever. Unfortunately, as we discussed earlier, it is much easier to instill fear in people's minds, and it's hard to remove wrongful information or to sway people off wrongful information once it's actually been put in their mindset. There's also science on that. And that's the real challenge that exists, is that there are so many channels of information, some of which are producing and supplying misinformation, some of which are unfortunately going that step further and supplying disinformation. And the challenge is that even as we try to connect with people who've fallen victim or subject to misinformation or disinformation, it's much harder to shift somebody's mindset off those perspectives than it is to put those wrongful ideas in their thinking in the first place.
We're chatting tonight with Dr. Eileen de Villa, the former head of public health in the city of Toronto. We're going to take a final break and come back with some concluding comments and ask her, why did she retire and what's next? Stay with us, everyone. Back in 2 minutes with the former head of public health during the biggest pandemic in the world's history since the Spanish flu back in what, 1917,
1918, yes, that's
Stay
right.
with us, everyone. Back in 2 minutes. Welcome back, everyone, to the Brian Crombie Radio Hour. I've really enjoyed chatting with our former head of public health in the city of Toronto, Dr. Eileen de Villa. You've retired. How come? Like, it sounds like, you did one of the most important jobs that you could ever possibly do. Why'd you give it up?
Well, I think your answer is right there, Brian, right? I did one of the most important things, challenging things that anyone could ever do. Really significant to be part of that COVID response and to have that responsibility. It was truly all consuming, to say nothing of the other public health challenges of the last 8 years. So for me, having, achieved what I could within the context of responding to COVID and such an all consuming sort of endeavor, it was time for me to step away, right? To actually have a little bit more time for me and for my family, who sacrificed a lot, particularly over the last few years.
So are you going to take a break or retire or
Yeah,
do something
yeah,
new?
Brian, like many people who've worked in the health system in the last few years, I stopped working on December 31st. I was fortunate to be able to be away for most of the early part of this year. I just got back a few weeks ago. And frankly, you don't even realize how very tired you are until you actually stop. I know I'm not the only one who's had this experience, but when you've been on the hamster wheel, if you will, for a really long time and running at full speed, you don't actually realize how tired you are until you actually stop and take a moment to breathe. So I've been fortunate to be able to do that.
What'd you do? Go to Bali and meditate for a couple months?
Almost. I was in Southeast Asia for sure. My family's from the Philippines. I hadn't had a chance to see my extended family for a period of time. So I was able to go back and reconnect and recharge. And if you've ever been to the Philippines, you'll know what a happy and, right, as poor as it is, it's an incredibly joyful place, and the food is amazing. So it was a great time for me. And the weather, of course, it was nice to avoid winter. So I've had the chance to take a little bit of a break and am now back in the city and dabbling here and there, thinking about the next opportunity.
Well, I think that you played a very critically important role, and thank you for that. I've got to ask you as a final question, if I could, what are you excited about? One of the things that frankly got me a little excited was a report last week, I think, that came out that said that the shingles vaccine can dramatically reduce the probability of dementia.
Yes.
And number one, I have why the heck would a shingles vaccine help dementia? I find that amazing. And so since I've got to get a shingles vaccine, I thought that was kind of exciting. What things excite you in the sort of public health vaccine medical arena right now, if any?
Well, I think, the shingles vaccine, I read that report with excitement too. And I would encourage you and your audience to go out and get that shingles vaccine. If you're eligible, have that conversation with your healthcare provider. But what I'm excited about is that I think that through COVID-19, we actually had the opportunity to really see what is driving health in our city. I think more and more people are talking about the things that really underpin our ability to enjoy good health in this city. We are starting to talk more about mental health, right? And the impact of loneliness. And I'm seeing people really moving towards addressing that. We are understanding more and more the significance of food security and housing. And people are actually engaged in conversation on how we address these significant issues that are actually detracting from the health, not just of the most vulnerable in our city, but frankly, it's detracting from all of our health. And knowing that that kind of conversation is happening, and knowing that many of those conversations will lead to action, right? With the right leadership and with the right sort of oomph, we can actually really improve things in this city. And that really, I find very exciting.
Dr. Eileen Davila, former head of public health in the city of Toronto, thank you so much for joining us today. I really appreciate it. This has been a fascinating conversation. And I've got to say thank you very much for working so hard for so long, even if it cost you a little bit of time away from your family and other activities, because I do think that, as I said, former President Obama said, even though it's incredibly regrettable that anyone died, having a 20% of a 80% less mortality rate than the United States in regards to our response to COVID-19 in Canada. It's amazing, and it's people like you that encouraged us to vaccinate, to stay at home, to mask, to do the things that we needed to do, such that think about it. 4 out of 5 people that could have passed away didn't because of what people like you did, and encouraged the rest of us to do. So thank you very much for your efforts in that regard. I appreciate it, and all of Toronto
Thank you, Brian.
appreciates it.
Thank you. And if I can, really, the credit goes to the amazing people at Toronto Public Health and our colleagues throughout the city who really made the difference. They really did.
That's our show for tonight. Everybody, thank you for joining us. I remind you, I'm on every Monday through Friday at 6 o'clock on 960 a.m. As soon as my radio show goes to air, I post the videos and the podcasts on my website, briancrombie.com, on social media, on my YouTube channel, and on podcast servers. Thanks for joining us. Good night, everybody.